Welcome back to Easy Medicine. In this part, we continue with high-yield cardiology cases focusing on acute myocardial infarction complications and critical pharmacologic management. These are key concepts you need to recognize fast on exam day. Case 3. A 55-year-old man comes to the emergency department due to 1 hour of intense epigastric chest pain accompanied by sweating. He has obesity and diet-controlled type 2 diabetes mellitus. An immediate electrocardiogram shows normal sinus rhythm with 2 mm of ST segment elevation in leads 2, 3, and AVF. Aspirin and morphine are administered. Blood pressure is 110/70 mm of mercury, pulse is 60 beats per minute and regular, and oxygen saturation is 98% on room air. After administration of aspirin and morphine, the patient is transported to the catheterization lab for urgent percutaneous coronary intervention. He develops dizziness, and the telemetry monitor shows sinus bradycardia at 40 beats per minute. The patient appears pale and diaphoretic, and peripheral pulses are faint. Blood pressure is 70/40 mm of mercury. The question is, what is the most appropriate immediate step for managing this patient's condition? The correct answer is atropine. This patient with ST elevation in leads 2, 3, and AVF has an acute inferior wall myocardial infarction, which most commonly occurs due to occlusion of the right coronary artery. The right coronary artery usually supplies blood to the sinoatrial node, the atrioventricular node, and most of the bundle of His. Therefore, conduction impairment, sinus bradycardia, and atrioventricular block are common in patients with inferior wall myocardial infarction. Sinus bradycardia is the most common arrhythmia in these patients. It occurs due to both nodal ischemia and enhanced vagal tone triggered by infarction of myocardial tissue. Although the bradycardia is usually transient and resolves with restoration of coronary blood flow, patients with hypotension or symptoms such as lightheadedness or syncope should be managed with intravenous atropine. The anticholinergic effects of atropine counteract the enhanced vagal tone, increasing heart rate and improving symptoms. Case 4. A 40-year-old female with a history of depression and hypertension is brought to the emergency room after being found obtunded in her apartment. She is hypotensive and bradycardic on physical examination. Intravenous glucagon is administered, and her condition improves. The question is, which intracellular change is most likely responsible for this improvement? The correct answer is increased cyclic AMP in cardiac myocytes. This patient most likely overdosed on a beta blocker medication. Beta blocker overdose causes diffuse non-selective blockade of peripheral beta-adrenergic receptors, leading to depression of myocardial contractility, bradycardia, and decreased atrioventricular conduction, resulting in a low cardiac output state. Glucagon is the drug of choice for beta blocker overdose. It acts on G-protein-coupled receptors, increasing intracellular cyclic AMP and enhancing calcium availability during muscle contraction. This results in increased heart rate and cardiac contractility. Clinical improvement in heart rate and blood pressure can be observed within minutes. Importantly, glucagon works independently of adrenergic receptors. In the next and final part, we will cover more high-yield concepts including stroke mechanisms and coronary artery disease adaptations. Make sure to watch Part 3 to complete the full cardiology review.